Welcome back, everyone. Super excited to be continuing our guideline series with our second installment on asthma. As this is a new initiative that we started in 2025 and super excited about this specific guideline series. We're looking at the most recent global initiative for asthma, or GINA guidelines. I'm really excited to have you follow us and learn something from this along the way. As always, joined by Dave Fafaro. Ferf, how's it going?
Good. It's going well. Trying to stay warm. My cat is here huddled up with me. She loves the Zoom and people talking, and especially talking about asthma. So you guys may see or hear her, depending on how you're consuming this episode. Yeah, very excited to keep talking about the guidelines. I think this is the type of thing, accumulation of knowledge that we want to be able to give to people. I think we talk a lot about the individual trials. We talk sometimes about specific situations. But once you're practicing, you really need to have a global sense of what to do with patients. And this guideline series is to try to break that down into manageable chunks. And so people have a quick reference and can be more familiar with how we should best take care of our patients.
100% Firth. And yeah, excited to see you. I feel like there's only maybe one instance where I know that I do not bother you, and that's when the Buffalo Bills are playing. But condolences to the recent loss, but I hope you're doing okay. But I feel like
And
they
might
they
need to
had a
take a minute now that you mentioned it. I just need to regroup myself. It's a tough one.
now I know that I can go ahead and text you on a Sunday night if I have a question going forward.
Yes, yeah. You certainly
Well,
can. I may still have pangs of it here or there, so you can help console me if that comes up.
perfect. Thank you. Glad to be with you and always great to see you. And so excited to be joined again today by Rupali Sood and Tom DiAntonio, two amazing pulmonary critical care fellows at Johns Hopkins and our fellow co-leads for this guideline series. Tom and Rupali, good morning.
Good morning, everyone. Fun to be back.
Yeah, great to see everyone. Looking forward to our discussion today on this nice, cold, and frigid day.
Great. And for those that may not have listened to the first episode yet, hopefully you'll go back and be able to do that. But a quick reminder, in that first episode, we covered the diagnosis and assessment of asthma. So today we're going to focus a little bit more on asthma management, including both pharmacologic as well as non-pharmacologic interventions. We'll be discussing step-up therapy, the importance of inhaled corticosteroids or ICS, as well as touch on the topic of severe asthma and biologic therapy, but that's gonna really be upcoming episodes that we hope to include for y'all going forward.
Yeah, and I think we have a ton of great content to review today. We've talked about asthma a bunch before on the show, so we'll reference some prior episodes and we'll make sure to post them about inhalers and about management of certain trials and management of acute asthma flares. But we're really excited to look at this systematically. Just our standard disclaimer, this podcast is not meant for specific medical advice in specific cases. The views we express today do not necessarily reflect the opinions or policies of our respective employers. In any cases we discuss, have had identifying features removed to protect or changed to protect the identity of our patients. So, Rupali, why don't we start and dive in with a case to frame our discussion?
Sure, Dave. I'm happy to get us started with the case. I think asthma is something we all frequently encounter. So, our case today is a patient that came to me in clinic, a 32-year-old woman with a history of childhood asthma that's really been quiet for many years, didn't have too many problems. However, recently, it is the season, as Christina likes to say, she experienced exacerbation triggered by a viral URI. In that setting, she went to see her primary care doctor, who prescribed her a short course of oral steroids and refilled her rescue albuterol inhaler that she's been using daily for about the past week, though prior she was only using it occasionally. Despite this treatment, she's coming to see me in the setting of lingering cough and occasional wheezing. Christina, where would you start with this patient?
Yeah, thanks, Rupali. And I think such a frequent scenario that's definitely seen in fellows clinic. My precepted in residence clinic last week, and there was a very kind of similar presentation, as you mentioned, common that our primary care physicians are also seeing. So hopefully this is going to be applicable to a lot of different people listening today. But as you mentioned last time too, when we were talking about just the assessment and the diagnosis, I know you and Tom highlighted the first step is always to confirm the diagnosis of asthma. So in this specific case that you described, Rupali, we have the classic more than two pulmonary symptoms, so cough and wheezing, plus a positive response to bronchodilators and oral corticosteroids, which makes asthma very likely. So this is a very common regimen that's prescribed. However, it may not be that ideal. So Tom, when thinking about the updated guidelines, how would you approach treatment for this patient based off the recent GINA recommendations?
Yeah, absolutely. Thanks, Christina. Yeah, the guidelines have certainly changed a lot even since we learned about this in medical school. As you said, it's always very helpful to confirm the diagnosis of asthma and make sure we're treating the right thing. And the response to therapy is very supportive of that. The 2024 GINA guidelines really emphasize that the treatment of asthma revolves around the use of reliever inhalers, controller or maintenance inhalers, and or the combination of both. In the past, we relied very heavily on the use of short-acting beta agonists, which we commonly know as SABAs, as the primary rescue method. However, the current guidelines actually strongly advocate for inhaled corticosteroid containing therapies to be the backbone of asthma therapy. And this is true for both maintenance and reliever therapy. There's actually some pretty good evidence that the over reliance on SABAs alone increases the risk of exacerbations and worse clinical outcomes. And the data also shows that patients who use ICS containing therapy on a regular basis have better long-term outcomes. Dave, what are your thoughts on how this has all evolved over the years?
Thanks. Yeah, it's really an interesting process of continuing medical education. I think this is one of the great examples. I think another great example of something that people often learn or that is often prescribed that has changed over the years is, say, daily aspirin for cardiovascular prevention. And obviously, there's been a lot of evolving guidelines on that. But this is another one. You will often get patients who say they have asthma, they have an albuterol inhaler at home. When you start diving into it, there are maybe times of the year or consistently that they're really poorly controlled. But this is such a common medical problem encountered by primary care doctors in emergency department, in urgent cares, and in pulmonary clinics. And it's been the mainstay of therapy for so long that you will still all the time encounter patients who have asthma and are just using the SABA rescue inhaler. But we will talk about a little bit of the data that led us into this. There have been a ton of trials, especially in the last 6 to 8 years, that have investigated this and been really convincing. And we have changed our viewpoint of this from a pulmonary standpoint. And now it's on us to disseminate that knowledge and make sure that we're changing things. And so I can't tell you how many patients come to me on this inhaler regimen. And then I also often have a choice. I think we in pulmonary clinic, like someone is on albuterol, then they think it's fine. But when I do my assessment, I think there's some room for improvement. And so you have to convince people to change up their medication therapy and to talk about that a little bit. So as you pointed out, we know that now that if you are on a short-acting beta agonist and you need it regularly, that's also a caveat. This is not just a person who had a post-viral wheezing and needed an albuterol inhaler for a week or something like that. But if you're using it in somewhat of a regular fashion, we know that's associated with worse outcomes, worse in terms of asthma exacerbations. Also, increased risk of exercise-induced bronchospasm. If you measure airway inflammation or have markers of that, like we talked about in the first episode, like fractional exhaled nitric oxide, those can actually go up by doing this or remain elevated. And over time, you can actually have a decreased responsiveness to that bronchodilator, which makes it less effective. And so all of these have led to the thought that inhaled corticosteroid containing therapy should really be the mainstay and should be started from the start of asthma treatment. And we're just consistently messaging that. The guidelines message that. And that's part of this episode too, is making sure people are aware of that. So the guidelines encourage using this at the diagnosis of asthma. So Rupali, I was hoping you can dive in a little bit more about how we think about implementing inhaled corticosteroid therapy in patients with asthma being diagnosed, or for example, this patient that you presented to us.
Sure, Dave. Happy to dive into this a little bit more. So, the guidelines really recommend that we use maintenance and reliever therapy, which is referred to using the acronym MART, as the preferred approach, which means that we prescribe a single inhaler that contains both an inhaled corticosteroid and formoterol, which is the LABA component of this, for both daily maintenance and rescue relief. MART therapy allows patients to adjust their medication according to their symptoms, leads to better asthma control and fewer exacerbations overall. The backbone of MART therapy is that it requires formoterol, the LABA component, to be a part of the therapy. In the United States, the currently improved inhalers for MART therapy are budesonide formoterol, which is Symbicort, or generically available as the Brena inhaler, or mometasone formoterol, which is Dulera, which is off-label used as MART therapy, given that it contains the formoterol component in it. The dosing of these medications is generally twice daily. These medications are divided into low, medium, and high designation. That is based on the steroid component of these medications. For example, in Symbicort, 80 mcgs is considered low, 160 mcgs is medium, versus with Dulera, 100 mcgs is low and 200 mcgs is considered medium. Dosing is generally going to be 1 to 2 puffs twice a day, and high dose is considered using the 2 puffs twice a day in terms of the steroid component of the medium dose inhalers. The daily maximum dose, however, of these MART inhalers is actually based on the formoterol component of these inhalers, which is about 8 to 12 puffs a day for Symbicort and 4 to 8 puffs a day for Dulera. Dave, you have something to add?
Yeah, thank you for reviewing that. I think there's a couple really important points to just highlight in there. One is really thinking about the max doses and making sure people have a clear understanding of what low, medium, and high is. Because often you might prescribe this and you just select 80 or 160 or, 1 puff or 2 puffs. And you should really have to talk to your patient about what they're using to know what doses they're at. Christine and I felt strongly about this, this is a hard part of pulmonary medicine. And we have our Pulm Peeps inhaler guide that outlines all of this for people. And we'll make sure to share that with this episode, but it's good to get familiar with this. And then one thing I also just wanted to highlight is, as you mentioned, this understanding is really surrounded around formoterol as a long-acting beta agonist. That being said, we have patients who have insurances that still don't preferentially favor these inhalers. And we can get into a long discussion about insurances and the impact on inhalers and how that sometimes impacts our treatment. And so we will always be trying to stick as closely to the evidence and the guidelines as this and references formoterol, and then often because of that, talking about Dulera and Symbicort. But I think we've all had patients whose insurance favors another agent that might have a different long-acting beta agonist. And we often try to extrapolate this data to mimic some of these dosings using a different inhaler. And we're sometimes just stuck with that. And so that is just to mention, if you have a patient and they say, I really can't get this, the copay is too high, you can try to take that same data and extrapolate it to the other inhalers that are available. But if you don't mind, where did this come from? How did we get to this understanding that these are the types of inhalers and dosing that we should be using?
Yeah, first, thank you for that, Dave. That's exactly right, is that we're really emphasizing the inhaled corticosteroid component of this and specifically thinking about it in combination therapy, like we mentioned with MARTA, the ICS LABA. However, many of our patients don't qualify, and commonly we'll see patients in other generic or brand indications like Advair and things like that. And the GINA guidelines actually have a really helpful table where you can actually look at the components of how much steroid are in each of those inhalers to do a comparative side by side. So definitely nice to have those to reference as well. But getting back a little bit more to just MART therapy to better understand it. I know as a fellow, I was always trying to understand this therapy and think of where did all this new evidence come from? Why are we talking about this sort of every day in clinic? And so I'll just focus on that for the next few minutes. But Symbicort is really the best studied MART therapy inhaler in the US trials, which is currently why it is usually what we recommend when we're thinking about guideline adherence MART therapy. So there have been multiple trials done since about 2018 up till 2022, where we're investigating this question of MART inhalers in US trials. So Sigma 1 and 2 were trials done in 2018, followed by the Novel Start trial in 2019. These two trials were nice in that they used PRN Symbicort in the setting of mild asthma versus PRN SABAs to look at a few outcomes of exacerbations and preventing these exacerbations, symptom control. And they basically found that the PRN Symbicort was better in reducing exacerbations and also limiting the amount of overall steroid exposure that patients experienced. This was followed in 2019 by the Practical trial. In this trial, PRN Symbicort was used in both mild and moderate asthma, but now compared to just daily ICS therapy. And it was found to reduce severe exacerbations with, again, lower overall corticosteroid exposure. In 2022, the Mandala trial was published. This trial is a little bit different in that it does not, as we had mentioned, include the formoterol component. It uses actually PRN budesonide albuterol, so a combination of an inhaled corticosteroid and a short-acting beta agonist. And it was found that combination itself was more effective than just PRN alone albuterol or SABA therapy in reducing severe exacerbations. This patient group was moderate to severe asthma, so a little bit different. I will just put the caveat on this that this was the most recent trial, but it was technically not a MART trial, again, because it didn't include that formoterol component, but more evidence to add to show us that the ICS component is really an important component in controlling even moderate to severe asthma in those patients. I will note that the non-formoterol ICS and the ICS-SABA are not technically part of MART therapy, but like we discussed, we extrapolate and do the best we can based on the patient in front of us. Formoterol is really liked in these guidelines because of its rapid onset, its longer duration. So to summarize our discussion thus far, the key MART benefits are that there is one inhaler that our patients can rely on and use for both maintenance as a daily inhaler, and then also at rescue at times when their symptoms are exacerbated. This therapy prevents the overuse of SABAs, which was mentioned in this trial, um, had some downside effects. And then real-time up titration of inhaled corticosteroids is available with this inhaler therapy and avoids symptoms worsening. And then it also reduces overall steroid exposure, which we know in the long term can lead to increased infections and other problems for our patients. So that's just a way that I like to think about MART therapy specifically and why it's been so up and coming in the last few years.
Awesome, Rupali. That was so great to walk us through that. And I think specifically the last 1 to 2 sentences, highlighting and summarizing everything together was fantastic. I think that for those that want to learn a little bit more about patient population, the methods that were used, and some more nuances, I think it is a great opportunity to listen to some of the rapid fire journal clubs, which we have been done. So Novel Start was a controlled trial of budesonide formoterol is needed for mild asthma. That was in the New England Journal of Medicine 2019. And then the SMART therapy meta-analysis was published in JAMA 2018. And we have both of those as rapid fire journal clubs on Plum Peeps, where Luke Hedrick, one of our associate editors, as well as Furf, were able to walk us through that. So definitely take a listen as you're trying to go through this. As you mentioned, Rupali, Mandala was not part of the SMART therapy. So I think there's an opportunity for us to have that as an upcoming rapid fire journal club, which I'm excited about as well. And one of the things that you mentioned, Rupali, too, right, is just what's the practical component of this? And I think some of this can also extrapolate. We're having an outpatient setting. You as a pulmonary fellow, residents, of house staff, or primary care physicians are thinking about what to do with their patient that you're prescribing. But I think this is very applicable as a pulmonary fellow when you're getting consulting from a team in the inpatient setting. Right. So you can't just in your note for planning recommendations, like just be like, just start MART therapy. So this is like a just really great way for fellows to start thinking about what exactly does that mean? How can I be helpful to colleagues? Was telling them like I would recommend Symbicort, but if this is not available, then I would recommend this as an alternative, and really being strategic and concise with like low, medium, high designation, because those are not always as apparent. So I think we have the ability to really be great with consultants as we're thinking about MART therapy, both in the inpatient and the outpatient setting. And to just transition a little bit further, Rupali, to extend on what you were saying as far as these are the recommendations, but what do the GINA guidelines actually say about how we divide asthma treatment? And they actually have 2 tracks which emphasize the importance of MART therapy. So they have track 1 versus track 2. I feel like I don't have a sports analogy for this as I did for type 2 inflammation and non-type 2 inflammation. So we're going to keep it pretty simple here. So track 1 is going to be the preferred track in the recent guidelines. And this is going to be where the use of ICS formoterol as both maintenance and reliever therapy, or as MART, as you walked us through, Rupali has described. So for patients with mild or infrequent symptoms, this could be an ICS formoterol just used as needed. And this track's recommended for most patients due to better adherence as well as fewer exacerbations. The track 2, or their alternative track, is slightly different. So it involves an ICS or an ICS LABA taken regularly with a separate SABA or ICS SABA for symptom relief. So this is going to incorporate the short-acting beta agonists, which some of us may traditionally have used before these recent guidelines. So this track, an alternative to use if needed if ICS formoterol is unavailable, or if patients prefer a different approach than track 1.
Yeah, that's exactly right, Christina. And I think that the presence of the 2 tracks harkens back to what we talked about in the first episode, where so much of, providing effective asthma care is building a relationship with our patient, personalizing the care that works for them, and incorporating best practices. As you alluded to, track 1 is very much the preferred approach in the GINA guidelines. It ensures that patients are receiving an anti-inflammatory reliever. These have become known as AIRs in place of our typical reliever, which is just a short-acting beta agonist. The benefit of these is that using anti-inflammatory relievers, whether it's an ICS formoterol component or an ICS SABA drug like was used in Mandela, they reduce the reliance on using beta agonists on their own, the short-acting SABAs. If a patient ends up on track 2, whether because of what their formulary covers, what is cost affordable to them, personal preference, in those cases, we as the prescribers need to do a really good job of emphasizing the importance of the use of that inhaled corticosteroid component drug. Because what can not infrequently happen is, especially in folks who have infrequent symptoms, they will use the inhaled corticosteroid less frequently and become more reliant on the SABA, putting them at higher risk for worse outcomes. So it's really on us to review inhaler use, make sure patients are getting good education, and explain why we're trying to make the recommendations we are. So I want to talk about how the guidelines recommend stepping up therapy. And I think what is important to take away is that they don't really talk about the idea of mild, moderate, like we used to think about. Really, the severity of someone's asthma now is almost more determined by the type of therapy that he or she is needing. So step 1 therapy in track 1, again, that's the ICS formoterol component. So step 1, step 2, those are your patients who have pretty infrequent symptoms. They're having symptoms 3 to 5 days or less per week. It's not a huge burden to them, but they are having these symptoms. This is the perfect person to start on a PRN low dose ICS formoterol. They're using that inhaler 1 puff as needed for symptomatic relief. If they're having a little bit more frequent symptoms, now you're into step 2. These are your folks who are having symptoms most days of the week, or they're having nighttime awakenings. Those are the people where MART therapy enters the picture. You're going to use low-dose MART therapy with ICS formoterol, and that's going to be used on a twice daily basis. And then as needed, they are able to use that same inhaler to provide them symptomatic relief. If things are a little tougher, now you're up into step 4, and that's where you have persistent symptoms. These are the tougher, challenging cases to manage, and fortunately, they are less common, but they are overrepresented in our pulmonary clinics. So these folks have persistent symptoms. This is where you're going to step up the dose of the steroid. Like Rupali was saying, the inhaled corticosteroid component is what determines whether this is low, medium, or high. So usually you're going to be stepping up to medium dose MART therapy and continuing to use low dose formoterol containing agents as relievers. Step 5, this is where we're entering into the range of severe asthma. And as Christina said, we'll talk about it in a future podcast, but this is really where you're getting into the range of you're specifically phenotyping your patients. You're considering starting them on biologic therapies. You may trial the high dose corticosteroid for a month or 2 to see if they get some relief. And you're thinking about adding on additional controllers and or short courses of corticosteroids.
Thanks so much, Tom, for walking us through that. I think this has always been how we've thought about asthma and our step diagrams. I agree. Now the new diagrams have less of that. You're saying first mild, intermittent or persistent, mild, moderate. You're really starting therapies and then assessing their control, as we talked about in the first episode, and somewhat of that rule of 2s that we can harken back to. And thinking about whether you need to increase the intensity of the regimen. I'll make a couple notes, again, making a plug that it's important for us to understand what low, medium, and high dose ICSs are, and referencing either the GINA guidelines or an inhaler guide, and you can see the ones attached to this episode show notes. One thing I'll also note is that even in step 4, it's really not recommending standing high dose MART therapy. And this is important. I do get patients who are referred to me on max dose Symbicort maintenance therapy, 160 twice a day, every day. And that is not really where we want to live for these patients. So we should be thinking about alternative therapies. On that note, we were going to talk later about biologics and persistent oral corticosteroids. But there are other medicines that are used for asthma. They're a little bit more prominent in some of the older guidelines. They're mentioned somewhat in the GINA guidelines. but there are supplements to these inhaler regimens that we can sometimes think about. So Tom, pharmacologically, what are those other options? And globally, what does GINA have to say about them?
Yeah, absolutely. Thinking to our world of chronic obstructive pulmonary disease, our other main inhaler is a LAMA. They don't feature prominently in the therapy of asthma. We know that in COPD, LAMAs are the backbone. In asthma, corticosteroids are the backbone. But they do have a role in the management of very, very challenging, severe asthma. So other controller options, and usually, as Dave was saying, we don't go right to those high doses of corticosteroids. It's actually the GINA guidelines would actually recommend you put one of these third controllers on WABA, ICS, and a third controller before going on to those high doses of corticosteroids. But things that you can consider are LAMAs, leukotriene receptor antagonists, the most common one being montelukast. They do make the comment throughout the guidelines that if you were going to prescribe someone montelukast, you counsel them as to the risks and benefits of using this drug given its potential neuropsychiatric side effects. You can try and determine if people have particular allergen triggers, dust mites, cats, seasonal allergies, and it may be an opportunity to refer our patients to our immunology colleagues for immunotherapy. And then azithromycin also has a little bit of a role. The guidelines do mention these, but they definitely don't play a major role.
Yeah, and I think that there's still therapies that can be helpful. I think they mention the guidelines because they know that there are patients who benefit from them. And I think the only reason maybe they're de-emphasized some is we have less clear guidance from the data of who to use them with and when. I think if you have a clear allergic phenotype person, that it really early on having sublingual immunotherapies or treatment desensitization can actually be really helpful. And so they do mention considering them. And that goes back to some of the importance of phenotyping, like we talked about in the first episode. I'll just also make one further note. We talked about this again, but when we're thinking about our lower doses of therapy, one thing that they are clear to mention is that we should be refraining from or trying to steer people away from daily low dose isolated inhaled corticosteroid therapy. And so you will get some patients who are on this. This is generally not recommended because it seems like when patients are on that type of inhaler that doesn't have that immediate bronchodilator response, they may not always have good adherence. And we'll talk about inhaler adherence going forward. And it may just lead to this cycle where they're using their breakthrough short-acting beta agonist inhaler too much. And we know that if we pair this with an ICS LABA inhaler, we can get better control to use that just as an as-needed basis. And so that's that practical trial that gives us that evidence to say that. And so we just try to avoid that therapy in these guidelines. The core principle here is that we are assessing, we're adjusting, and we're reviewing. So for each time one of these asthma patients comes to our clinic, we're trying to assess the degree of which we've controlled their symptoms with their current regimen. And then we're going to adjust that regimen. Often we think about the escalation. There's a big sections in the guideline about de-escalation as well, and we should adjust appropriately. And then we're also always reviewing how we're going to monitor things and modify that treatment process. So assess, adjust, review. The assessment at first is confirming the diagnosis. We're evaluating the symptoms like we talked about in episode 1. We're making sure they know how to use their inhalers. And then we're seeing where their symptoms are at currently. Adjustment, we're going to optimize the therapy just as we said with that step 1 through 5, thinking about what track they're on as well. And then we're going to review, we're going to monitor the response and modify the treatment as needed. And this is an important one. I think you should tell your patients to be reaching out to you or keeping a log. It's not the make an adjustment, I'll see you in 6 months or a year, and we won't review until then. We should try to be a little bit more active than that if we can.
Yeah, thanks, Dave. That is perfect. The assess, adjust, review is a mantra I like to think about, especially with these asthma patients, because it's such a crucial process. And this cycle really helps us ensure that we provide personalized care and that we tailor those to our patients' needs and really meet them where they're at. The GINA guidelines strongly emphasize this as a backbone of taking care of these patients. Beyond medications, however, we do the guidelines, and in clinic, we often do discuss non-pharmacologic interventions that we can talk about with our asthma patients that are also an important part of their therapy. In the guidelines specifically, there are a few interventions that are mentioned. These include smoking cessation, I think as pulmonary doctors, this really rings true to us, and we spend a good amount of our time often talking to our patients about smoking and different methods in which we can aid them in smoking cessation. And just to mention, nowadays, smoking includes many different things, not just tobacco. We should talk to our patients about vaping, marijuana, and other forms of allergens and other sorts of exposures that can be harmful over time. The second thing the guidelines talk about is weight reduction in some of our patients, as that has in some analysis have been shown to be associated with worsening asthma, though the evidence is not strong. The other thing the guidelines talk about is physical activity. Though it doesn't directly reduce inflammation, it can be helpful for our patients overall. They also strongly talk about avoiding triggers. And I think we've mentioned this multiple times that, especially in that sort of type 2 allergic phenotype of asthma, avoiding allergens and these occupational exposures. Sometimes our patients are even working jobs where their exposures are part of their daily job. I have patients in clinic who are exposed to chemicals on a daily basis, cleaning products on a daily basis, and that can also really oftentimes be a trigger of their asthma and worsen their symptoms. The guidelines do mention that there are ways to mitigate some of these exposures, including talking to our patients about air purifiers and HEPA filters, which I sometimes show my patients and pull up on Amazon as something that they can purchase. And there's low cost options and coupons for as well that patients can use to get these sorts of things in their households. And then really talking about vaccinations is the next thing. And that includes all our usual vaccinations now for flu and COVID and making sure that our patients are protected because as Christina had mentioned in the prior episode, like viral URIs can be a big trigger for asthma exacerbations. And the last thing the guidelines mention is really focusing on managing other comorbidities, thinking about reflux disease, sleep apnea, anxiety, and depression is something that can actually worsen asthma control in a lot of our patients. So, really thinking about our patients overall and their health in general. While the direct evidence for a lot of these non pharmacologic interventions does vary, these strategies the GINA guidelines emphasize will improve overall health and quality of life for our patients. So, something we should really be thinking about and very easy to talk to our patients about in clinic and really get to know a little bit more about them as well. So, we should encourage our patients to incorporate this in their asthma care plan when we do this sort of constant cycle of adjusting and reviewing with our patients.
I love that, Rupali. Thank you so much for just talking about the importance of pharmacologic as well as non-pharmacologic interventions. And I was just thinking as you're talking about the first one that you mentioned, just the importance of smoking cessation. I think there's a lot of like newer medications and therapies and techniques to be able to do that. So I think we have also another opportunity to do a specific episode on smoking cessation and using some people that really get to have expertise in that, also share their recommendations with listeners. So lots of exciting things to come, I think, as one of the summaries from today. But we've also covered a lot of ground, which I think has been really important on the second episode that we're focusing on asthma, really from ICS formoterol as a preferred treatment, the stepwise approach that we talked about, as well as Rupali, just the importance of the non-pharmacologic interventions that we should be thinking about when we're seeing patients in front of us. So with that, though, Rupali, let's go back to the patient case that you started this episode with and let us know how you followed up with her.
Yeah, great idea, Christina. So this patient, I think the most important thing we just talked about, right? Assess, adjust, review, right? So if we come back to the patient that day in clinic, first thing I did was confirm this was actually asthma, think about her a little bit more, try and phenotype her, brought her back to, at that time, she continued on her PRN, just short acting beta agonist. But then the question really was, how do we think about the next step of therapy? We talked about inhaled corticosteroids as a next step. But as Dave was mentioning, some people just need their inhalers right after they've had an infection for a little while. But then the question is, how long does that last? So I brought her back to clinic about 2 weeks later. Unfortunately, cough was still lingering, wheezing was still coming. So that was time to use our rule of twos, assess her symptoms, and then decide what do we do next. So we know the backbone is really this corticosteroid component. So at that time, we were fortunate enough that we had run things through her insurance and ICS formoterol in the form of Symbicort was available to her. So we were able to start her on low dose ICS formoterol. During the first visit, we had sent those scripts and said, please fill it. And she had filled it. She had started to use it PRN. And then when we brought her back at the second visit, she was continuing to have some of those symptoms. So at that time, you can consider putting your patient on the daily maintenance dosing of this ICS formoterol and then encouraging them to use that same inhaler as needed, which she was already doing. So we were able to step it up and say, let's use the same MARC therapy as your daily maintenance inhaler and then use it as needed. as well. And that really was starting her on that track one of therapy that we discussed and then stepping it up as needed. This way, our thought was we could provide symptom relief and long term control, and we're addressing that inflammation right from the start. And we always have to bring them back to adjust and review. So moving forward, bringing her back to assess those symptoms later on, but really using these guidelines to guide her therapy.
I think that sounds like a really solid plan, Rupali. And as you said, you're going to bring her back for follow up. This is not a here's your inhaler, see you in a couple months. You're following up closely with her, reviewing technique, adjusting her therapy. One thing that I actually like to do, and this is something that, if our listeners out there use an electronic medical record that allows you to use dot phrases or type up instructions for patients at the end, I've actually created a dot phrase for myself that I put in with every patient's checkout information that asks them, please keep track of how many times you're using your reliever inhaler. If you go to an urgent care, if you see another doctor, if someone gives you a course of steroids, please let me know because we want to see you more frequently. So just a little bit of a plug for using the technology that's available to us to provide better instructions for our patients.
Yeah, that's a great point, Tom. I also think that making sure the patients know when it's okay to use their inhaler or not. I think a lot of people have preconceptions or misconceptions about not wanting to become reliant on an inhaler at times or not understanding when their symptoms are flaring and they should be using more PRN or communicating with us. Is having that asthma action plan clearly stated out with them. It's just a huge part of their treatment. And part of some of those non-pharmacologic interventions, just making sure that they understand what they can do, what they should be doing, avoiding triggers, trying to identify what those triggers are if we're not totally sure, and that they have a clear understanding of their inhaler technique and their treatment regimen.
Awesome. I think this case today really highlights the practical application of the GINA 2024 guidelines in really day to day clinical practices. And that was a hope of this series for those listening today. So, by following the track one approach, focusing on ICS LABA therapy, and really providing personalized patient education, the hope is that together as a community, we can really help patients achieve better asthma control and longer term outcomes.
Yeah, so I think with that, we'll wrap up today's discussion. Thank you guys so much for Polly and Tom. This was great. I think a really nice next step in our series, and I'm looking forward to the next episode when we'll think about therapies for severe asthma that's not controlled on this current regimen and specifically focusing on biologic therapies. So thank you all for listening. This episode was written by Tom and Rupali, edited and produced by myself and Christina Montemayor. Music's original music by Eric Rogers, and we'll see you next time.